thanks again for both of them. Dr. Abdulaziz.
Our webinar tonight. It should be a very special webinar. Indeed, I want to thank Dr. Saeed bin Hamri for his great work over the last few weeks for bringing all distinguished speakers to discuss a lot of topics related to endourology. Of course, also our thanks to SUA and our colleagues in organizing all these webinars. Tonight, as I mentioned, we are pleased and honored to have very distinguished speakers from Canada, Dr. Boujani and Dr. Zorn, and both of them are working at University of Montreal as Associate Professor of Urology. Dr. Naeem Boujani did his fellowship 2 years in BPH and stone disease and established comprehensive kidney stone and BPH programs. He has published extensively in same field. Same thing for Dr. Zorn. He did 2 years fellowship in University of Chicago in MIS and oncology, and his main focus of clinical and scientific interest in the surgical treatment of BPH and prostate cancer, especially in GreenLight laser therapy and other techniques. He published more than 250 papers and 12 book chapters. Also, he developed the University of Montreal robotic and laser BPH programs. So we are really pleased to have them tonight with us. And without delaying more, we ask Dr. Boujani to start his talk. As planned, we will give each speaker about 20 minutes to finish his talk, and then we'll have about 30 minutes to discuss and to comment. So please, Dr. Boujani. Dr. Boujani will talk about Aquablation and Enucleation and HOLIPS, and then Dr. Zorn will talk about GreenLight and Rezūm. Please, Dr. Boujani.
Fantastic. Can you see my screen?
Yes.
Oh.
Yes, we
okay.
see.
All right. Fantastic. Thank you so much. Thank you to the Saudi Endourology Group for inviting me and Kevin Zorn to present. I want to thank the moderators, Saeed and Abdulaziz. I want to thank the organizers, Adele, and my former resident, Ahmed Al-Askar. It's really an honor and a privilege for us to be speaking to you all today. We'd like to have a discussion at the end, so we'll try to get to our presentations and really have some discussion with all of the participants. So these are my conflicts of interest. I'm going to begin just by talking a bit about the spectrum of treatment options that are available for BPH. I think if you look at this diagram, there's a couple of things to note. First, if you increase invasiveness of the treatment, you increase efficacy. So it's clear that currently, if you're not going to get the same result if you do an open simple prostatectomy or an enucleation versus an office-based procedure. That's not to say that one is better than the other, but there are advantages and disadvantages of each procedure. The other thing I want you to recognize here is the amount of options that are available. There's a tremendous amount of innovation that has occurred over the last 5 to 10 years that has given us many, many options now that we can offer to our patients. If we just look at the University of Montreal, where me and Dr. Zorn practice, we offer both office-based procedures, so Rezūm and UroLift. We offer simple prostatectomy, open and robotic, which is done rarely now because of our enucleation techniques. We offer monopolar, bipolar TURP, as well as button. For enucleation, we offer holmium laser enucleation of the prostate. We offer GreenLight enucleation of the prostate. And I'm happy to announce in a couple of weeks, I'll be doing SOLEP, Soltive thulium fiber laser enucleation of the prostate. We also offer GreenLight, vaporization and vapoenucleation. And of course, we offer Aquablation. So I really feel that this is really the golden age of BPH surgical technique. And it gives us really the opportunity to tailor our technique based on the patient, based on not only the patient's prostate volume, not only on their comorbidities, but also based on their goals and objectives. What does the patient want out of surgery? I think this is very important. I'll give you 2 quick examples. A patient who wants to maintain their antegrade ejaculation we would offer them either Rezūm and UroLift if they have a small prostate, or Aquablation if they have a larger gland. A patient who doesn't want to have a large surgery, who just wants a quick replacement for medical therapy, we would offer them an office-based procedure. So we're really in an age of surgery where we can tailor our therapy to the patient. There's one disadvantage to this, and that is that there are many, many options that are available. If you take a patient who has a 40 to 50 gram prostate, they have about 8 options available to them. And it's difficult sometimes for patients to decide what's the best option for them. And so I'm happy to announce that we just completed the first Canadian BPH surgical decision aid. This is the first page from the decision aid. And basically, it's a tool that patients go through to learn more about BPH, and then they can learn more about the different procedures that are available to them, advantages and disadvantages. And then it goes through a series of questions that allows them to decide what's best for them. And then they can have a more informative discussion with their urologist. So we just completed this. We'll be alpha testing it soon, and it should be available for clinical use shortly. So what are we going to discuss today? We're going to discuss enucleation. I will then talk about aquablation, and then Dr. Zorn will finish with GreenLight and Rezūm. So enucleation. I want to preface my talk by saying that I am quite biased. As mentioned by Dr. Abdulaziz, I did 2 years of fellowship in Indianapolis, where I did a lot of enucleation. So often my answer is enucleation, enucleation, enucleation. Please note that I mentioned enucleation as I don't believe the energy source makes a difference, and we'll talk about that in a minute. So the gold standard is still considered to be monopolar bipolar TURP. Vaporization, Dr. Zorn will talk about GreenLight, and I'm going to focus on enucleation. Gold standard of enucleation is holmium laser enucleation of the prostate. However, there are many more options now available for enucleation. If you look at the literature, the number of articles looking at enucleation is increasing significantly over the last 10 years. And in the last year alone, there's over 100 articles looking just at enucleation. So it's an evolving field with different techniques, but also with different energy sources. So again, the gold standard is the holmium laser enucleation of the prostate. You have the holmium laser, which everybody knows is a pulsed laser at 2100 nanomicron wavelength, and fire, which is very important. Laser penetration, depth of penetration is 0.4 millimeters, excellent coagulation, and minimal necrosis. Longest study to date is by the late Dr. El Halai, who did a lot of work with HOLIP, almost 1,000 patients. He's now up to 18 years, I believe, that they've recently released the data. Average gland size is 81 grams. You have a nice decrease in IPSS from 19 to 4, increase in Qmax from 8 to 27. This is 10-year data. Very rare secondary procedure, less than 1%. Urethral stricture and bladder neck contracture rates are very low. Some transient stress incontinence, and then a wonderful PSA reduction of 84%. We also looked at this compared to patients who are anticoagulated during my fellowship. Basically didn't show much difference in terms of hours of hospitalization, length of continuous bladder irrigation, hemoglobin drop, and transfusion rate. HOLIP has been compared to TURP, many studies, less complications, shorter length of catheterization, shorter length of stay, lower transfusion rate, and significantly greater improvements in IPSS and Qmax. It has also been compared to simple prostatectomy, glands greater than 100 grams, identical AUA symptom score and Qmax at 5 years, significantly less complications, lower transfusion rate, shorter length of catheterization, and shorter length of stay. What about a different energy modality? So there's a lot of interest with bipolar plasma kinetic enucleation of the prostate. This is using the Gyrus plasma kinetic superpulse system, 160 watt cutting and 80 watt coagulative power. It's a bipolar system. Along the study is a 3-year study, almost 250 patients. Gland size was 100 grams on average. Of a nice Qmax increase from 7 to 28, IPSS dropped 24 to 4, very rare urethral stricture and bladder neck stenosis, no incontinence, and a PSA reduction of 65. So a little bit lower reduction in PSA, but very nice results using a different energy modality. It has also been compared to TURP, and very similar, you have less complications in TURP, shorter length of catheterization, shorter length of stay, lower transfusion rate, and significantly greater improvements in IPSS and Qmax. It has been compared to open civil prostatectomy. We only have 1-year data, significantly less complications, lower transfusion rate, shorter length of catheterization, shorter length of stay. This is another energy source which has been studied quite a bit in Germany in particular. So this is a laser, the thulium laser, which is very similar to the holmium laser. However, the main difference is that it's a continuous laser and not a pulse laser like the holmium laser. It's also an end fire laser. Laser depth of penetration is 0.25, excellent coagulation and some charring. You can actually see the charring in the video, which is one of my one of the things that I feel makes this laser a little bit less appropriate, especially when you're learning enucleation. The planes can be a little bit harder to find, but once you get over that learning phase, as you'll see, the results are very similar to HOLEP. Longest study to date is a 5-year study. You have a mean prostate gland size of 50 grams. Qmax increased from 7 to 16. IPSS dropped 21 to 5. A little bit higher bladder stenosis and stricture rate, maybe due to the scarring and the charring of the tissue. 3 patients did require a secondary procedure, and you have a very nice PSA drop, very similar to HOLEP at 79%. You can also compare it to TURP, very limited data, however, and it's very similar to TURP. It hasn't been compared to simple prostatectomy. There's even people doing enucleation with the diode laser. So there's different wavelengths for the diode laser. It's also an end fire laser. Depth of penetration is a little bit deeper, has very good hemostatic properties, and it's very inexpensive. Longest study is not very long, it's only 6 months. These are prostates of 65 grams, but they have shown very nice results with a nice increase in Qmax from 7 to 19, a nice drop in IPSS from 23 to 7. This is very short-term data though, and a PSA reduction of 65%. It has been compared to TURP, and again, very similar results to TURP, and has not been compared to simple open prostatectomy. Finally, we also have GreenLight enucleation, which I've done about a dozen cases now. I was very interested in looking at the literature, and I was surprised that there wasn't much literature out there. I'm not going to get into the details of how the laser works, as Kevin Zorn will be talking about that in a few minutes. The nicest study that I did found was again by the late Dr. El Halai, and he compared GreenLight vapoenucleation to HOLEP. These are 80-gram prostates. He found that the symptom score was very similar. The change in symptom score at 1 year was very similar between the 2 techniques. However, Qmax was a little bit higher in the HOLEP group. And also the decrease in prostate size was also smaller, or a better decrease in size in the HOLEP group compared to the GreenLight vapoenucleation group. And then one last thing that we'll talk about in a minute is the cost. HOLEP is a lot cheaper than GreenLight. So these are the many advantages of enucleation with basically any energy source. There are, however, 2 main drawbacks of enucleation. The first is the length of the procedure, and the other is the learning curve, which we hear a lot about. In terms of length of the procedure, this is frequently reported as a problem with enucleation. However, if you look at the mean tissue retrieval rate, so grams per minute between HOLEP and TURP, they're actually very comparable. And the difference is that HOLEP removes much more tissue, as evidenced by the decrease in the PSA. In terms of learning curve, we're looking at about 20 to 30 cases with a mentor. If you try to do HOLEP without a mentor, you're looking at about 50 cases. So it is a steep learning curve. I think the best way around the learning curve would be to teach HOLEP during residency, which we try to do at the University of Montreal. So in summary, in terms of enucleation, so endoscopic enucleation of the prostate, there's an increasing amount of literature that has demonstrated that energy source is really irrelevant. But it's exciting because people are getting more and more interested in enucleation because of the positive and long-term results. It has the best BPH outcomes, short and long term. It's independent of prostate size. The largest I've done is 500 grams. So really you can do almost all prostates with enucleation. It does provide a tissue specimen, so very important. In our series, about 9% of patients who have been worked up for an increased PSA have had cancer on their pathological specimen. Majority of them have been Gleason 6/10, but we've had some 7s and some 8s. So this is another advantage of enucleation. The reintervention rate is very low, below 1%. It can be done in patients who are anticoagulated, and it's inexpensive. The laser fiber, the scope, the morcelator blades are all reusable. So that will end my talk on enucleation, and I'm going to move on to aquablation. Before I get to aquablation, I want to present very quickly a study that we've just submitted for publication. This is a study because Kevin Zorn and I and a number of our other co-authors are interested in the importance of sexual function for patients with BPH. So we did a survey and we asked 150 men who are planning to have BPH surgery, and then we asked 150 men who had previously had BPH surgery in the last year. And we asked them what was most important to them. What were the most important factors that they evaluated before surgery and after surgery? And as you can see here, in the men 50 to 59 years old, almost 90% of them, their most important thing was sexual function. And this was equally split between erectile and ejaculatory function. 60 to 69-year-olds was 70%, 70 to 75-year-olds was 50%. And then the importance of sexual functions decreased a little bit in the men above 76 years of age. The other things that were important were incontinence and pain upon urination. So just to give you an idea that ejaculatory and erectile function is quite important to our patients and should be considered when deciding on which surgical options to select. So we'll talk now about aquablation. So aquablation is the use of high water jet to ablate prostate tissue. It has previously been used in different industries, as you can see here, and the natural progression has been to use high water jet to ablate prostate tissue, which is heat-free. So here is the machine. If you haven't seen it, we have a nice HD screen to map out the prostate. You have a foot pedal and you have your handpiece, which you can see here. This handpiece will go into the urethra. So this procedure is done in the operating room, patient in lithotomy. This is the handpiece which goes into urethra. Before we place the handpiece in the urethra, we place a transrectal ultrasound. So the procedure is done with transrectal ultrasound and with your handpiece, which has also the endoscopic view, which I'll show you in a minute. With the endoscopic view, you can identify the sphincter and the verumontanum. And then with the truss in place, you can decide what you want to ablate. So this is how you plan for the surgery. In the transverse plane, you decide what part of the prostate you want to ablate. And then in the sagittal plane, you do the same. You identify the median lobe, the bladder neck, the mid-prostate, the verumontanum. And sorry, I just got to move this over. And we can also, we can also identify the verumontanum, which is here, and we also have our scope. If you can appreciate the scope that ends right here. So the scope is placed at the sphincter, so we know exactly where the sphincter is. And then the robot basically decides on how they want to ablate the tissue. And the surgeon can adjust this, as you can see here, depending on how he feels comfortable and what he wants to ablate. Now you can see this area here is over the verumontanum and right in front of the sphincter. And so this tissue here is going to get a different sort of cut to preserve the verumontanum. And so here's the procedure. The actual ablation time takes about 4 minutes, depending on the length of the prostate. And this can be repeated depending on the size of the prostate. Here you can see the endoscopic view, and this is actually the butterfly cut that's done at the verumontanum to preserve the verumontanum and to really try to maintain the continence of the patient and the ejaculation of the patient. Postoperatively, so two things really important. First of all, there is almost no learning curve to this procedure. As I'll show you in the studies, most of the urologists had no experience with aquablation when they entered into the studies that we'll look at. Postoperatively, however, there is some learning to be done. So at the end of the case, we do manual irrigation, we remove the clots. There is some tissue specimen, but it's very small. We then place a Foley catheter, and then we use this catheter tensioning device. This catheter tensioning device was used for Water 2, one of the studies. It is no longer being used, and I'll explain why. So the first study that was done with aquablation was the WATER study. This was a double-blind prospective randomized clinical trial comparing aquablation to TURP. So these are patients who had prostates of 30 to 80 grams. IPSS greater than 12 and a Qmax less than 15. And you can see here it was TURP versus Aquablation, 116 to 65. Looking at IPSS was very comparable. Average prostate gland size was 50 grams. The Qmax, again, comparable, and ejaculatory and erectile function was also very comparable. Primary endpoint was efficacy, so the drop in IPSS. So there was no difference between Aquablation and TURP in this group of patients between 30 and 80 grams. Symptom score, as you see, up to 12 months, no change. In terms of Qmax, again, no statistically significant difference between Aquablation and TURP, drop in PVR also. In terms of safety, there were less complications associated with Aquablation than with TURP, as you can see here, measured with the Clavien-Dindo classification. In terms of ejaculatory function, the majority, above 95% of patients in the Aquablation arm maintained their antegrade ejaculation versus the TURP arm. So it was superior to TURP in terms of maintenance of ejaculatory function. In terms of operative time, so very similar. As you see, TURP kind of increased slowly as the prostate got bigger, 36 minutes versus 33 minutes. In terms of resective time, however, TURP again increased over time with the size of the prostate. The time of resection with Aquablation did not change. On average was 4 minutes to resect a prostate up to 80 grams. They then did a sub-analysis, which is very important. They looked at prostates between 50 and 80 grams, so the bigger glands. And what they found was, again, obviously safety was better in the Aquablation arm. They also showed that the drop in IPSS was better in the Aquablation arm. And this actually led to the WATER 2 study, which is the one we were a part of, which I'll show you in a minute. So the WATER 1 trial, which is the Aquablation versus TURP trial, 30 to 80 grams, is now at 3-year data. This was just presented at the AUA. And the efficacy has been maintained at 3 years compared to TURP, as well as quality of life. And if you look again at the subgroup greater than 50 grams, Aquablation was found to be superior to TURP in terms of IPSS changed. And this led us to WATER 2. In terms of Qmax, no change, and PVR also no difference between Aquablation and TURP. PSA reduction, very similar again between TURP and Aquablation, and the retreatment rate again was comparable with TURP at 1.5% per year retreatment rate. So we then move on to the WATER 2 study. So these are prostates between 80 and 150 grams. Now, the interesting thing with this study is that now we're talking about glands that, other than Aquablation, the only options are enucleation, which people have difficulty learning, and open simple prostatectomy, which has its own complications. And so this became a very interesting study. These were the sites that were involved. Me and Kevin Zorn were involved with this study. So this study was a single arm, had a total of 100 patients. The big difference is the size in the prostate. Everything else was the same. So these are 80 to 150 gram prostates. So average prostate volume was 100 grams. The time from truss in to catheter in was 55 minutes, so very quick. Most of these patients underwent 2 or 3 passes of the ablation with Aquablation. So each pass was about 5 minutes. And so it's about total resective time was about 15 minutes. Length of stay was 1.6 days, and total catheter time was 94 hours. At the University of Montreal, we were able to send 2 patients home on the same day of the procedure. So here's the drop in IPSS. So a nice drop of 16 points. Qmax, very nice increase. Prostate volume was remeasured 3 months after the procedure, and it dropped by 44%. In terms of safety, so the number of complications went up compared to WATER 1, however, was acceptable at 45%. Most of these were grade 1 and grade 2, and we'll get into what they were. We then presented the 1-year data last year. And here, the interesting thing is, obviously, IPSS was maintained. Qmax also was maintained. But what was interesting was the ejaculatory and erectile function was maintained. No erectile dysfunction occurred. In terms of ejaculatory function, 80% of men maintained their antegrade ejaculation. Now, this is unheard of. If you compare this, so we're talking about 80 to 150 gram prostates. If you compare this to enucleation or open simple prostatectomy, those patients do not have ejaculation anymore. So this is a nice option for patients who want to maintain their ejaculation and have large prostate glands. I'm going to just cut off from the Water 2 study for 1 minute. We've just submitted this paper for publication. We basically looked at patients who had aquablation done, and those who had antegrade ejaculation maintained and those who did not. And because this is done under ultrasound, and because we know exactly the amount of tissue we resected, we're able to identify which patients will maintain their antegrade ejaculation and which ones won't, and what is the main factor. And what we found was the main factor in patients who maintained their ejaculation was the depth below the verumontanum. So if you go too low below the verumontanum with your resection, patients lose their antegrade ejaculation. And so it's very interesting to be able to objectively determine what causes this ejaculation problem after procedures. And so this has just been submitted for publication. So back to our Water 2 study. Our main complication that we had was bleeding. This has come back many times over. The rate of bleeding was 10%, and this is too high. And just to preface this, we presented the data from our Canadian patients. We had 20 patients and there were no transfusions. So there's something going on post-operatively, and some of these patients were bleeding more than others. And so we did a study to look into this. So we looked at 800 patients after Water 2. So these are all commercial patients. And what we found was the traction device that we used during Water 2 actually increased the bleeding. And because most of the bleeding was coming from the bladder neck, and when we put this tractioning device, we increased the bleeding. So if you can see here, this is with the tractioning device, this is without the tractioning device. And these are prostates up to 280 grams. And so the tractioning device has been obviously discontinued. So we've decreased the rate of bleeding. And then the other thing that we're starting to do is at the end of the procedure, we go in and look at the bladder neck. If the bladder neck is bleeding, we will cauterize it. If not, we just put the catheter in and then the patient goes to the PACU. And now the bleeding rate is around 2% as opposed to the 10% we saw before. A little bit higher in the large glands, 3 to 4%, and almost 0% for the smaller glands. So in terms of Water 2, again, these are the 80 to 150 gram prostates. We're now at 2-year data. This has recently been published, and everything has been maintained: symptom score, Qmax, PVR drop. PSA reduction, we have about a 40% PSA reduction, which fits with the decrease in size of the prostate by about 40%. And the retreatment rate is about 1%, so very acceptable retreatment rate at 2 years. So in summary, in terms of aquablation, we've demonstrated that it has excellent BPH outcomes at 2 years for the very large prostates, 80 to 150 grams, and up to 3 years for the smaller glands below 80 grams. It's independent of prostate size, up to 150 grams. It is very fast. Even for those very large prostates, up to 150 grams, we're able to do it below an hour, and that includes time from beginning to catheter placement. Rare ejaculatory dysfunction, so patients are able to maintain their antegrade ejaculation for the 30 to 80 grams, and then up to 150 grams, 80% of them maintain their ejaculatory function. Very low reintervention and acceptable reintervention rate. And it's urologist independent. I think this is a main advantage of this procedure. And what I mean by this is there's no learning curve. So in the Water 2 study, looking at prostates 80 to 150 grams, 90% of the urologists who went into that study had never done a procedure before enrolling their first patient. So compared to a learning curve of 30 to 50 cases with enucleation, this becomes very attractive. And because it is under trust, guidance, ultrasound, it's quite predictable. Another great procedure, and I'm going to now send off to my colleague, Dr. Zorn, to present GreenLight, vaporization, vapoenucleation, and some enucleation, and he'll also be talking about Rezūm. Thank you.
So great job, Naeem, and can everyone hear me okay?
Yes, yes. Welcome, Dr. Zorn.
Thank you.
We know it's mid of the day in Montreal. It's not like here. We're almost 10 p.m.
I can see that there's the darkness, but here, I think Naeem and I have put up our nice background. But you can look at I can turn it off and you can see my office. I'm in my office right now, so lots of pictures of kidneys and prostates. But just to change it up, because I'm sure everyone's sick and tired of looking at the same kidneys and prostate. So,
Sure.
so first off,
you have 20 minutes, Dr. Zorn, if you can finish your talk, please.
Absolutely, yeah. I'll move it along, and I've been reading along some of the questions, and maybe we can get to those as well. How do we, efficiently counsel patients with this portfolio? Naeem was so nice to cover some, hot topics of enucleation and aquablation, and to take this time to thank everyone for the invitation for the SUA, and have a pleasure to talk about something very passionate to me as well. So, do I have control over the slide deck, guys?
I think.
Yeah, you can share your slides if you want.
Do you have yours, Kevin?
Yeah,
I share yours.
I was just kind of. So that's what I got the slide deck, the master, the one you sent to me, and I'll go to slide 29, and I'll go here and
share your screen.
I'm not a master of the Zoom, as Dr. Bojani is a master of this. So how do I share slides, guys? Here, let's see.
It's at the bottom, next to chat.
Okay, I have to open it. There we go. Here we go. Beautiful.
There you go.
Show share screen, and it's the
choose the PowerPoint.
Okay.
Yeah.
Share.
Got it.
Beautiful. Okay, good.
Perfect.
So we're done with the intro series. I'm going to be talking now about GreenLight and some of the evolution and techniques, which again, having my interest for GreenLight, but also having trained with El Halali. Let me see if I can move to the next slide. There we go. So some of my disclosures, aside from GreenLight, Boston Scientific, Rezūm, Procept with the Aquablation, and some of the studies we're doing now with even office-based procedures, ZenFlow, and a balloon that's used for stricture Optaloon, Eurotronics, the company, and they're looking at this balloon dilation and anterior commissurotomy with paclitaxel. So my background is I learned my first BPH surgery with Dr. El Halali Holak for 4 months. And then I did a TURP. And I was like, what is this? This is unbelievable. I've only learned this anatomic approach and learned GreenLight. So a little bit of my background, and to have been fortunate to have offered a lot of these treatments. And GreenLight, and I think, since 2006 when it first came out, and the XPS system in 2010, I think we've seen a numerous amount of literature on it. It's recommended by all the guidelines and several randomized studies. And, it really is something that has a place, particularly for the anticoagulated patient. So we're going to get to that. Relatively low complication. And I don't know about you, now having done these GreenLights, I don't have to worry about keeping the patient overnight, or checking the sodiums, or dealing with bleeding. I think there's equivalency in TURP outcomes for the smaller prostates under 80 grams, and very short hospital stay. And while we can say that the fiber is $800 of fiber versus a reusable holmium fiber, there's still a major improvement in the cost of hospitalization and 30-day emergency visits and during the global period. So that has to be factored in. So yeah, I think the literature is there, and we all know that we can remove tissue and at the same time create a buffer of a coagulated zone. And that's really dependent on technique, and I won't get into too much of that, but the idea is that we can create an opening of the obstructive tissue in the adenoma, and at the same time benefit from the coagulative necrosis, which will allow for a hemostatic procedure. But, without a question of a doubt, 100 years ago, urologists wouldn't have the same job we have today. I mean, the average age life expectancy 100 years ago was just pushing 55 years of age. And today, with all the technology and all the benefits of, socialization and hygiene, we're seeing growth rates. We're seeing 90-year-old men. That wasn't an issue before. So I think the global life expectancy is almost doubled. We have to factor in too with that. Let me jump ahead here. These are our doubling of time. So we're getting a lot more of an elderly population, and the global population's increasing, and urologists, we're not doubling at that speed. And with that, our friends, the cardiologists, are also publishing the benefits of anticoagulation therapy. And we're seeing a lot more aspirin and DOAC, direct oral anticoagulants, being in our patients. So these patients are coming in with bigger prostates, and they got big vascular prostates. And we have this population to deal with, and GreenLight has that role. It's well proven. So I think there's a tremendous amount of data to support. It's a safe and effective treatment, reduce bleeding, and reduce complications in the first 30 days. So I think everyone on this phone call or on the Zoom has someone who this is a very common place if you're a urologist practicing BPH, the big prostate and you're anticoagulated. What's in that bag of tricks? And here's our guideline recommendations. So one of the questions is, what do I counsel patients? Well, I have always in my office my, printout of my the white screen kind of blanks it out, but it's pretty much this AUA or the CUA guideline recommendations based on volume. And I ultrasound everyone. I use a handheld ultrasound, which I can show a little later on, called Clarius. So during my exam, we all know this is not a great tool. Ultrasound is a great tool, and we're publishing on the equivalency of the transrectal versus the transabdominal, and the efficiency, especially after 60 grams, is pretty bang on, especially for the median lobe. So based on that, here's your criteria, but we also have a categorization if you're on anticoagulation, and that bucket list is a lot smaller. So jumping ahead, we published that, since the HPS to the XPS, we're more efficient. If you look at the blue, that's the XPS. In the top left, the operative time is faster. We're actually able to reduce about 30% of the operative time because of the higher power laser. And with the fiber, it's more durable. The bottom right, you can see 1 fiber per case. The time where we start pushing more is around 120 to 150 grams. So that's what we're showing here in the dollar sign. Next up, bigger prostates, they take longer. So one of the disadvantages of doing GreenLight on a big prostate, it's like painting a wall. So if you have a gymnasium to paint, it's going to take you a lot longer. So that's a factor, especially when you're going over 80 grams. I book my GreenLights as a GreenLight 160 or a GreenLight 120. So everyone in the room, the anesthesia, the nursing, all know of what to expect. When you compare the outcomes for the larger prostates or the smaller, you can see that across the board, the efficiency of IPSS, the quality of life, the Qmax are very similar. The drop in PSA, obviously, the bigger the prostate, the bigger PSA density. But relatively speaking, when you're using 4 kilojoules per gram, so that's one of the metrics that we've published and others as well, if you're doing GreenLight, that if you're using, if you're operating on a 60-gram prostate, you should be using 240 kilojoules. So, some people say, oh, GreenLight doesn't work. And let me look at the operative report. Oh, 80-gram prostate and used 80 kilojoules of energy. You did a channelectomy. You really didn't open up that much. And that's the one way that a trained eye will acknowledge whether or not what was done was appropriate. Because that's one of the things that, as we know, BPH surgery is our best secret. Other than a video recording of the surgery, you cannot, as a patient or another urologist outside of doing a cystoscopy, quantify what has been removed. With TURP, you get the prostate tissue, the hole up, you get that. You have to do a good job because you have to find the capsule. There's only one way to do a hole up. There's many ways of doing GreenLight. So in experienced cases, the bigger prostate codes the problem. You have over 100 grams. This is where you don't want your first couple of cases to be this size because they tend to be longer. From this multitude study of over 800 patients at multi-institutions with bigger prostates, we saw that there was probably a higher tendency to undertreat. So less than 3 kilojoules per cc. And we can see the retreatment rate up to 3 years of pushing around 10%. So I think some people like to say, oh, GreenLight has a higher retreatment rate. Well, it depends who's doing it and the technique they're using and what they have. And led out to Dr. Misra and a few others doing GreenLep, the idea of the energy doing the surgery. But as we know too, as Dr. Bojani had nicely said, enucleation is EEP, enucleation of the prostate, assisted by the Stort's sheath and sprinkled on by the laser energy. So people say the holmium or the whatever it is, the energy that's used during an enucleation, I think probably contributes to about 20-25% of the surgery. A lot more are the skilled hands, and then the morcellator, that's really the job that removes the BPH. So, this is just an example of the major defect, the complete transition zone ectomy, the cure of BPH. This patient will not recur. And we know from the whole-up data, the retreatment rates tend to be from stricture disease. But on this phone call, I think there's 70 people, and I don't know how many people are doing enucleation, but there's a learning curve. And if you're already in practice outside the comfort and protection of a fellowship or a residency, most people don't want to take that chance personally, and it's a slowdown in your busy practice. You're not economically reimbursed for learning a new technique. And there's a cost to the patient, incontinence, issues of bleeding as well. So the learning curve, as Dr. Bojani mentioned, is long. And even in a very experienced post-training, like if you're in practice now and getting a mentorship program, the abandonment rate's probably over 50%. And this was a study reported by Bertrand Lucas of 9 centers, only 5 continued on and 4 actually are still doing hold-up. So it really tends to be what I consider the disciple fellowship. So you have El Hilali, Lingaman, Dr. Gilling, and their disciples who've trained and continue to train. So outside of residency, it tends not to be a procedure that's adopted later in practice. And a big reason, at least in the States, is if I learn to do hold-up or not, I don't get paid more. The actual reimbursement of a laser vaporization or enucleation is a very small amount. And as we know, the operative time's longer. And as a hospital, you don't get any more reimbursement for the additional equipment of acquiring the resectoscope, the morcellator and those blades. And those are not free. So that kind of eats into it. And I think that's typically why they tend to be in academic centers and not in the peripheral centers. So that's for that. And there's the transient incontinence, which is sometimes not always discussed, but there are patients who have to go through physiotherapy. And I believe this is just because of the more aggressive apical dissection. That's where we initiate enucleation. And for that, with time, those will improve, but that's a concern, especially in the older age. So I think, residency training, Bojani had mentioned, Dr. Bojani, is that, not every center where we practice and training, this is the 13 centers in Canada, everyone's doing open, everyone's doing TURP. But if you look at the other techniques, there's a very discordant impact. And also very strong interest. While everyone on this Zoom call will agree that open prostatectomy is the gold standard, in Canada today, we're looking at around 4 cases per year per training program. And that's for all residents. So the question is, are we training our residents today to comfortably and independently perform OSP on a regular basis? And I think the answer is clearly no. And enter the GreenLight vaporization incision technique. These are some of the techniques that you can use the laser, but to incise down a capsule, similar to what we would see for hold-up, but not need the morcellator. So this is an adaptive technique, which we published on, breaking it down into the floor, the lateral lobes, and then managing that. So I think that allows for early recognition of the capsule, consistently do the same procedure, and as well avoid morcellation and its complications. So we want to mark the sphincter. So no matter what you guys do, if you can just mark the sphincter before you start whatever surgery technique you do, it provides a landmark in which not to pass beyond to cause incontinence. So that's an easy little thing I showed others. Then creating an open, the standard PVP for those who do PVP, just create space, turn concave to convex, and then drag the fiber as you would do for hold-up, get down a capsule. And then once you're at the capsule, you'll create this mound of tissue, vaporize. And then some men who are 90 years old, you've done enough. You're just going to get their catheter out. You don't need to treat the lateral lobes. And that's an option you have with this technique. And then ultimately you do the lateral lobes, and then you're going to go ahead and use your loop to get the tissue out for pathology. So we're able to typically get between 8 to 10 grams of tissue with this technique. And that's sufficient for assessing of tissue. There is this technique of allowing for minimal coagulative necrosis by side firing along the capsule versus at it. Some people use low power and just do PVP, and they're leading a lot of necrotic tissue, so that takes longer to heal. And then this is the chart I like to show people that no matter what you do in your technique, you have to go through an inflammatory phase. So the more necrotic tissue you leave behind, you may have these patients with calcifications and so forth. And that's more technique. So this is what I expect with GreenLight and enucleation-like defect with early identification of the capsule. And just for whip through some of these, we've actually compared PVP to this VIT technique. And you can see that for comparable prostate volumes around 83 cc's, it took a little bit longer, about 20 minutes more to do the VIT. But if you look at the number of kilojoules per gram, at 4.8, we were able to deliver more energy. And if you look across the board, the IPSS improvements, the PSA reduction, we're able to get 63% reduction in PSA, comparable to that of some of the hold-up. So ultimately, these patients, I think, did better cross from propensity matching for PSA reductions, and they had less clinical visits of the dysuria and so forth that we would see with standard PVP. So VIT is a safe and efficacious technique. And in terms of durability, you know, at least in our series, we published on our we're moving on our 7th year now, but 5 years looking at a retreatment surgical of 1.1%. We published on that. So I guess the summary here, the GreenLight, it's a versatile, it's a Swiss Army knife. And with this, you can interchange between GreenLight, and if you're not happy with your technique, well, you can come back to the capsule or the center and start doing your PVP. You can auto convert with GreenLight. You can't do that with other laser technologies. And you have a variety of different approaches, as you can see here. And again, the VIT technique, which we published on, is an advanced technique for durable outcomes and reduced dysuria. It's reproducible, and it's something that's easily to teach to others. And so that will conclude that. I guess now I'll move on to Rezūm, and there's an extra slide here. Aquablation. I'll jump through that. I think now you switched around because of timing, so I'll jump ahead to the Rezūm, which should be coming up. Summary slide, this is a good sign. Here we go. Rezūm, okay. So the Rezūm, I guess everyone has heard of this technique and the idea of using steam as a vector of energy to deliver a slower impact, but a size reducing technology and technique for BPH. We all are aware of the combat study, which you see on the slide ahead of us, and it's kind of our go-to starting medical therapy. And with time, those improve. They come with, unfortunately, side effect profile, particularly the 5 ARIs with sexual dysfunction, and a long-term cost, not only to the system, but also to sexual performance. And that's a long going, typically once we start men on this, they always like to ask, how long do I need to be on it for? Well, typically forever. And that's something that we just become, you know, we don't think about, and we just continue on. And if they're not doing well, we'll hear some Viagra. And again, the total drug cost when you look over a lifetime is substantial. This is the system, the device, and it's, to me, truly the only office-based procedure. While UroLift can be done in the office, you have to, per injection of suture, you have to fill and empty the bladder. Okay, this is not a multi-firing gun. So typically this is a 30 to 40 minute procedure, and most often are being done in ambulatory care centers with propofol or some form of spinal. Whereas the Rezūm, I do all mine under a periprosthetic block as I would for a biopsy. And the procedure time is around 5 to 6 minutes. And the gun, once in, can deploy 15 injections, which you can do within 9-second intervals. So it's a really quick procedure. It's very similar. You don't need to buy additional materials for the UroLift. You need to buy a pediatric bronchoscope, because that's the only thing that fits on the sheath. Here, everything comes together. All you would need is your 30-degree lens cystoscope, which we all are owners of by Storz. So really that's all you need, and a liter of saline. The rest is just a modified computer, which generates RF heat, which heats the steam, which is 1 cc, is delivered over 9 seconds. And as we know from our physics days, steam has energy. And once it changes phases from steam back to water, it disperses a lot of energy. So per injection, you're delivering, a little less than 300 calories per injection. And that changeover to heat any cell to 70 degrees Celsius within milliseconds, you can see in time, causes cell death. And with the interstitium between these little cells, these circles, the steam can disperse through very homogeneous, unlike the days of tuna where heat was propagated from a metal tine, the steam is able to transmit through the cells through a convective method rather than conductive. So you don't get charring, you don't get the same necrosis as you would with previous technologies. And here you can see, if I'll play my video, it works, here we go. So this is just a real-time ultrasound and endoscopic view of the needle. As you can see, the white tine on the right, it's brought back 1 centimeter from the bladder neck. And really, once you press the button, a motor advances the needle 1 centimeter under the tissue. So there's really no operator dependency. Once you inject, you press a second button, and during which time you can see here an ultrasound, which is not necessary for the procedure. This is just for scientific delivery and demonstrating the zone under ultrasound that's treated, which is around 2 centimeters. So it's compartmentalized, as we know from doing HOLEP. There's a capsule, and that keeps the steam trapped. So it's not going to go elsewhere. It's not going to get into the rectum. It's not going to treat anything else but the transition zone. And each treatment is 9 seconds. So here we go. We will retract the needle. I don't need to empty the bladder. There's minimal bleeding. I can do patients on anticoagulation. So that's the benefit of the Rezūm. And when you do the first-in-man studies using MRI data, we can see a reduction over the next 6 months of approximately 40%. So 30 to 40% reduction in prostate volume, which we don't get with UroLift. Here's one of our patients that we treated in the past where we've seen not only the shrinkage of the prostate, but the reduction in the median lobe. So in the initial Rezūm data, over 30% of men had a median lobe. You can treat the median lobe. It works well for median lobes. And here's one of our patients from 6 months after, where you can see the defect created by the treated zone and a reepithelialization, and that there is a de-obstructed prostate. And that's very similar to what I would expect to see, maybe not as big, but this is a GreenLight several years out being followed for bladder cancer. So there is impact. The block itself, as I mentioned, typically I'll do, if you're doing your own biopsies, I'm very familiar and comfortable doing transrectal ultrasound. Unfortunately, not everyone is trained in Ontario and British Columbia. Urologists are not allowed to do transrectal ultrasounds. It's done by radiology. So fortunately, we're able to, and we're able to code and bill for it. So if this is something you're doing locally, which I believe in Saudi you can, am I right? Anyways, we'll answer that later. But the injection is, I typically will use more lidocaine. I will inject typically under the seminal vesicle in the prostate, which you can see here as the white area around the seminal vesicle. I'll also I'll pierce through the seminal vesicle. So with my needle, I'll advance through the seminal vesicle and freeze above the seminal vesicle under the bladder. And that's where a lot of those, if you do radical prostatectomy, that's where your neurovascular bundles come into the prostate. And I find you get a deeper anesthesia there. And then I'll do another 5 cc's at the apex, where we would do a spacer, injecting at the apex and let it go underneath the prostate. So that's 40 cc's, 20 on each side, wait 15 minutes, some viscous lidocaine, and our visual analog scales of pain scaler is around 4 on 10. So very tolerable, done in the office, and within 15 minutes, you're done. The downside is you have to leave a catheter for some days because you're inducing some swelling before the benefits. Most of the outcomes are seen between 1 and 3 months. So that's one of the downsides, is that while you are doing these benefits, it takes time. So if you have a patient who's in retention, we'll talk about it, but right now it's not your go-to technique for someone with a catheter dependent. We have done series, and Kevin McVary published on about 70% outcomes in that older, frailer population where no one else wants to operate on them. And I've done series like that too, but with the expectations, you're going to keep the catheter for at least a month, and we'll do a trial of void with a 70% aspect that you will be able to void. So there is time dependency of the outcomes. So again, I think it's indicated for those between 30 and 80, with or without median lobe. And I think, you can do anticoagulated patients. It is truly an office-based procedure. And in the days of COVID, my numbers have grown because everything else is bottlenecked. We can't put them to sleep. We can't go to the hospital. Patients are with catheters. This is an option. And if you do this, you can do anything else thereafter. I don't think this is like radiotherapy where you obliterate space and you make this an impossible any other surgery. So that's it. I think the 4-year data, now the 5 years being released, was supposed to be at the AUA and it is in press right now. But in summary, with even up to 5-year data, the retreatment rate's only at 4%, 4.4. And most of those patients were probably undertreated. They were only doing between 4 injections. And what we've learned is that for every 10 grams, so 80-gram prostate should have around 8 injections. And that's, again, anecdotal and something we're kind of looking at. How do we tailor the size or the injection number based on the configuration of prostate? So here's some of the demographics from that study. You can see the IPSS of near 22, prostate volume around 50 grams, slow flow. Again, we excluded patients in retention. And this is the money shot. This is the one I like to show patients who are interested in this, because I tell them for the next month, you're not going to like the results. You're going to have an inflammatory response before you see the oasis. It takes a good month before we get there. And so those are the patients I floor with anti-inflammatories and alpha blockers and explain you're going to pass slough tissue. At 1 month, you see the results improving, and by 3 months is where we plateau. But the IP, compared to Euroflow, the Eurolift, you can see the Qmax is substantially larger. And the impact on IPSS and quality of life are also up there. And there's preservation of ejaculatory function. That's it. The Rezūm 2 is another study looking at the larger prostates and those with median lobes. Ultimately, those with median lobes did just as well than the technique. Again, the downside, the potential for retention. In these initial series, catheters were coming out after 2 and 3 days. So I keep my catheters for a week. Just let them know that this is what we expected. I'm doing bigger prostates in these series, 40 grams. Most of mine are 60 to 80. And you're going to have some dysuria. That makes sense. You're thermally burning the tissues. 4% retreatment. And again, medical failure, about 5.2%. A lot better than the other MIST techniques. In some sense here, the summary here is that, you know, it's a durable outcome up to 5 years. We know now. We'll continue studying these patients. Sustained improvement. There hasn't seemed to be any worsening of symptoms. And even with median lobes, it's a good candidate for patients. And bang for buck, when you look at cost effectiveness, this is a study coming from the Cleveland Clinic from Dr. Ulrecker, you know, Rezūm's up there with in terms of, you know, improvements in IPSS to the total cost. One gun, that's all you need is a disposable outside the computer, which is the box, is $1,200. Every Eurolift suture in Canada is $1,000. So if you're putting in 6 or 8 sutures, that's a ridiculous amount of money. And if, you know, with the Rezūm, I can do up to 15 treatments. So cost effectiveness, I think there is a benefit favoring Rezūm. So again, it's another versatile tool. It's an office-based procedure. I don't know anything else that's really a truly office-based procedure without a propofol drip and an anesthesia at the bedside, which some, you know, in the States, they call that an office-based procedure, but you need the environment to have that. It's really a fast procedure. Within 10 minutes of getting started, you'll be done. It's anatomically precise to the transition zone. It truly is a sexually preserving procedure. You can treat the median lobe. And as I mentioned, there's an end effect, which is a prostate reduction around 30 to 40 grams, 40 to 40%, and a success rate of around 96%. So that finishes up my Rezūm, and I was going to get into maybe a quick conclusion, and we can get into the Q&A. Does that sound good? Everyone's on mute, so I saw some head nods. All right, here we go. So it's 2020. What do we know? I think that, you know, as Naeem and I, we talked about, you know, back in the day, you have an appendicitis or you have one treatment. We're taking out the appendix. There's not much debate. There's not much discussion. Sign here. Today, we need to get into, tell me about your sexuality. How's your erections? How often are you having sex? What are your expectations? You know, we have this big portfolio, which Naeem has been great to start up this initial, you know, tool in a busy day. I don't have time, and neither does anyone on this phone here on the Zoom, to really get into the nitty gritty of all those aspects before making the decision. So it's a very cluttered space, and it's continuing to grow. We'll see more in the next 5 years. Number 2, the rectal exam. You know, we all have one of these, but let's be honest, just like our stethoscope, I don't think it adds a lot of value, right? You know, you're not going to really decide your decision based on what your finger feels, right? It's a cystoscope. Some people invariably get a sense of the prostate. But again, if you get your hands on a tool that's going to measure the prostate, I think that's the key. And outside of 50 grams and above, you can see those curves splay out. You really don't have much of a clue of prostate size. Here's a beautiful example referred to me for a 60-gram prostate. I see this patient. I do my cystoscope. I use my Clarius handheld. You can see in the top left, transabdominal. Takes about 3 minutes. And right there in front of the patient, you see, hey, look, he's got a median lobe. And look, the prostate's 130 grams. So let's counsel him appropriately versus a 60 gram. And Naeem's probably smirking too. And I'm sure others on the phone where, hey, right? I mean, if I bring you, say happy birthday, and I bring you your 8th birthday, you'll be like, you missed my birthday by many years, right? That's a big difference. This is double the size. But for BPH, it's one of the few diseases where we have 30 grams to 300 grams. That's a huge spectrum. I think part of the and outside of an ultrasound, which is non-invasive and takes 3 minutes to do and it's reimbursable, I don't know why this isn't being done more often. So I think the importance of getting something like this into your technology, into your practice, day to day, has such value, especially if you're doing elevated PSAs and other, you know, considerations for other diseases of the prostate. And TURP still remains globally the workhorse. So anything that looks like obstruction, we're just going to TURP because I'm comfortable. It's so easy to do. And it's the secret. If I just open up a little bit and get them open, hey, we're good. I think that's another aspect that to the patient, we don't need to remove too much tissue to improve IPSS. And to the patient, hey, if you come back in 4 to 5 years, hey, we're current business, and I'm not angry at that. So I think that's another aspect where to the patient, we don't really ask them, are you wanting to choose something that's going to be a lifelong treatment, or do you mind coming back in a couple of years? And we know that bigger prostates is what we're seeing more and more. Unless you're treating 40-year-old men, you're going to be seeing big prostates, and they take longer. They're more complex and have high complications of transfusions, revisions, and what have you. And outside of going and learning new skills like HOLUP or buying new accessory equipment that only has its place for enucleation, I don't think most people are getting on board. So that's where I see maybe the aquablation taking off in the near future. So part of the tools, this is what I have. I print it up, I put it in the medical file, and I go through each one. I have brochures on each of the techniques that I give to the patient, depending on their interest. And I use the guidelines as part of my notes. I just put a sticker or include it on the medical file. So medical legally, I've discussed with all the patients, all those options. So I've made it part of my notes. And I think the key elements is really knowing the prostate volume. I may be sounding like a broken record. We know in Canadian programs, all residency training programs, only 40% are actually including ultrasound as part of their pre-op workup. But for prostate cancer, MRI, PET scans, PSMA scans, big dollar procedures are being done because it's possibly cancer. But for BPH, oh no, we can't do an ultrasound. It's too long to do. When you compare the difference, you're like, wow, that's a really noticeable thing. So I think to get volume is key. Booking the OR time based on the size and the technique that you're going to use. And again, that personalized care of the age, the medical status, if there's a median lobe or not, and then digging into the bit of our jobs now to become a sexologist. How important is this to you? And then understanding your skills and equipment and your access to. So I think then, the current era of BPH treatments, we have a lot of options. The big prostates, we got to recognize, and if we can identify them, then, hey, look, you got a 200-gram prostate. Dr. Bojani is going to take care of you with a HOLUP, and stratifying. So identifying the right thing so you can give the person the one-shot treatment that's going to be right for them. And then the proper preparation, making sure if I'm doing a Rezūm, it's a lot more preparation, that it's not going to be great right away. You've got to counsel the patient. So it's worth investing that time beforehand than having someone disgruntled, resentful, and potentially litigious down the road. And assess your abilities, knowing your setup. And if you're a MacGyver, you're treating a lot of stuff and you don't have a lot of time to dedicate, find out what's easiest to implement into your practice. And then the idea of personalized care is the topic of our discussion today. So with that, I thank everyone, and we can open up the room for discussion.
Great, Dr. Zon and Dr. Bojani. That's really very interesting, very informative presentation. You exceeded the time a bit, but we really enjoyed it. So no problem. I think we can open the floor now for questions, but if you allow me, just for a small comment and a question. As you mentioned both during your speech, that counseling the patient is very important. And nowadays we have a lot of alternative therapies for BPH. So if we have this very common example, 60-year-old male with BPH, and he wants to shift from the medication to one of these procedures. And on the list there, we have the Aquablation and the Rezūm. So the question for Dr. Bojani, what's the advantage or the things that to make you offer him the Aquablation procedure?
Yeah, I think it's a great question. I think the first question I ask is, what's the size of the prostate? I think as Kevin mentioned a number of times, it really helps to make an educated decision for you and for the patient. So if the patient has, did you mention a size?
Let's say 80 grams.
It keeps getting
Good
bigger.
choice.
Yeah.
So the biggest difference, an 80-gram prostate, your outcomes with both procedures will be very similar in terms of even the data that we have. Rezūm is 4 years and Aquablation is 3 years. So very similar data we have. I think one of the biggest differences is the patient okay with having a surgery in an operating room. If the patient says, no, I just want an office-based procedure, it's a fairly simple decision. If the patient is open to a more, a robotic procedure, if he's into technology, a lot of patients will come to us and say, I want aquablation because I want a robot to do my surgery. So there's different aspects that will help us decide which procedure. But overall, I think the outcomes are very similar. Does the patient have a problem having a catheter for a week after the procedure? Then, we would move them towards aquablation. If the patient doesn't want to be in the hospital one night, then we move them to Rezūm. So there's a number of factors that we will look at. If he absolutely wants to keep his antegrade ejaculation, I might try to push them towards Rezūm because we know about 20% of the patients in the Aquablation Water 2 study lost their antegrade ejaculation. So I think there's a number of factors that we can look at to help the patient decide which procedure is best for them.
Great. Dr. Zohn, what do you think?
Yeah, I think that's the personal care. When you sit down with someone, we don't have the calculator to say, insert your finger here and let's take a blood sample. We're all used to biomarkers, right? We want something that's like a tree, a fork in the road. First thing's age. I have to say, someone comes in at 80 gram, aside from especially today more than ever, is the hospital, not just do you don't want to be in one, do we even have access to it? And Dr. Bojani and I can attest. I mean, it's been 3 months. If you don't have cancer, we're a holding pattern. So nothing's moving. And I'm not sure in Saudi, is it also similar where, non-urgent cases can be done? So to me, that's a roadblock. So that's just today. And we don't know, maybe in a year it'll be better, but there's that. And then the hospital stay as well. If you can, I would not say someone comes in, typically the patient comes, especially with the power of the internet, maybe Naeem can attest, but they come in already pretty knowledge. They know what expect. They're not kind of blank sheet, doc, what would you do? It's the other way around saying, doc, I have a younger partner, I'm remarried, this is important to my sexuality. And I like to break down, but sometimes there's some idea that this is a sexually preserving. So if you have anything else, it's gonna ruin your sex life. I'm like, well, what's important to you? And again, speaking amongst men, I'm not sure if there's, I think most men, it's about the erection and the orgasm. I think that's the most quintessential part of sexuality. Whether or not you have an antegrade release outside of, being like a movie star, I don't know if most men are movie stars. And, again, this is the idea that inside the partner, the lights are off and, hey, look, I rolled to sleep, I'm happy, I feel good. And that's what they expect. And if you're going to preserve that, we don't really put that across the board. Is that going to be lost with any of the other techniques? And I make sure that they understand clearly that if it is, and they want to look to see the visual output, then we get into the details. So specifically the ejaculation. So, and I think when you look at erectile function, doing laser techniques preserves the thermal spread to the neurovascular bundles more than like the button. And it's probably underreported. There's a lot more erectile dysfunction there. So getting a better sense of sexuality, and let's just say an 80 gram prostate, then the question is catheter dependent or not, and their Q max and emptying. So if someone's got a good bladder and, hey, look, I'm waking up at night, I don't want to take drugs, then I look at the Rezūm as a surgical pill. And outside an 80 gram in a retention where I can't operate, if they're looking, they're a young person, they really want to have, more things than the aquablation. But as we know too, health economics in Canada doesn't make the aquablation the most accessible technology. So that's it. I think it's a tough one-word answer to give to you. The answer is depends, and it breaks down to the things we talked about.
Great. The other question, if you allow me, it's about the pathology. Can you send some tissue on both procedures, aquablation and Rezūm?
So I'll answer. So aquablation, at the end of the procedure, we will remove tissue. It's like taking a tree and shaking it in the middle of fall. I'm not sure in Saudi Arabia there's as much foliage as in Canada. For those who, some smiles here, yeah, there's a lot of foliage. So you shake the leaves, you'll get some of that kind of cellular tissue, which kind of we were able to scoop up through the filter and send off the pathology as sort of a mush. And they did read it as some tissue. So we do get tissue, but it lacks a bit of the architecture for proper Gleason grading. if that's what you're worried about. And then the other, Rezūm, no, you're pretty much, your needle, you stick, you pull out, you pull back a centimeter, you inject. So you're injecting steam, you're like a sniper, you're in, you're out, you deliver 200 calories per injection for, let's say, 5 injections, and you're out. Because of the swelling, leave a catheter for a few days, and then you take it out after a week. So there is no pathology. The PSA reduction is minimal for the Rezūm. We don't have a great deal of literature on it. The Aquablation seems around 40 to 50% PSA reduction. And so I always joke around with BPH people are like worried about cancer. I'm like, if you're worried about cancer, go and do your MRI, do your biopsy, and then we get into the discussion. And I have not heard of any case where we've done BPH surgery, we miss getting some, transition zone prostate cancer as being a mortal type of disease. So even if you do find, and I do a lot of robotics, even if I find 6 months or a year later some BPH that I thought, and they have cancer, it's not like, oh boy, you had this or whatever we talked about today. I would not be able to do a radical robotic prostatectomy at all. So if you are worried, go ahead and do your biopsy, but I wouldn't use the pathology specimen from a GreenLight or a HoLEP as the holy grail to say yes or no, you've got cancer. Because we all know, we all read from the same book, Campbell's, most cancers occur in the peripheral zone. Canada, USA, we're sampling up here in the north. If you want to find cancer, it's most likely to be in the peripheral zone.
True.
I think we can refer to the enucleation data. HoLEP data tells us about 8 to 9% of patients who remove the entire transition zone will have cancer, even though they've been worked up with MRI and biopsy. And again, like Kevin says, the majority of these are 6 on 10, 5%. These patients are usually older. We follow them. It's very rare that we'll find a 7 or 8 on 10. It happens, probably 2 or 3 of them in my practice, but it's rare. He's absolutely right. That's not the indication of BPH surgeries for BPH.
Right. And I think part of the post-op, we should, again, if you look at the guidelines, there are no guidelines for post-BPH treatments of checking the PSA. So from GreenLight and HoLEP data, we should see a PSA reduction and a flattening forever. I'm more worried about when you don't drop to the appropriate number and you start going up. That's where I'll get the MRI. I'll do a targeted biopsy. We'll go from there. But
I do enjoy after HoLEP, because that PSA is so representative of what's happening. So those PSAs go down to below 1. I mean, you're good. And if it ever goes up, there's something going on. So it's been published a number of times, but PSA after enucleation is a wonderful thing, because that PSA is representative, and it's not, this 18, 19, you have no idea what's going on. So that's a real advantage of enucleation whenever you're worried about prostate cancer.
Great. Saeed, did you have any question there?
Beautiful presentation, both guys. And I have a very specific question for Kevin, and the other question for Naeem. Kevin, do you think what you have presented, you have a lot of experience with these minimal invasive surgeries, and very nice, shorten the operative time for the patient, less complication. Do you think we can offer this procedure and upfront for those patients, and instead of having them in the clinic every month, every 2 months? Do you think this technology will take us and cross I don't know, what do you think?
Well, here's what I really think. I think at the age of 40, I think all men should have man water, which is Cialis 5, a little bit of Proscar for the hair. I mean, everyone's going to laugh, but a little statin for your cholesterol. Think about it. I mean, prevention is the key. And as a urologist, with Cialis daily, which has, endothelial. So I'm saying this because I met with Larry Levine and some of the endothelial dysfunction specialists, Dr. Mulhall, who told me from a young age, they started themselves on a low dose statin, a low dose Proscar, and for their cholesterol statin. So these are their kind of mixtures. So that would be the dream, is that we don't have these 80 and 150 gram prostates. That happens starting 40 to 50. But aside of creating man water and selling that, I think the key would be in terms of to think about the cost effectiveness. And I think as urologists in Canada, where I write a script for Viagra and sort of Cialis or the Flomax and Avatar, it doesn't affect me. I just I'll see you next year. It's free. It's healthcare, but it's paid by the healthcare system. But when you add that up over a time, and Paul Whalen from at the time in Ontario looked at that, it's about $1,000 a year. And when you do the annual counting of yearly dual therapy, by the 4th year, if you did a Rezūm, you just, anything going on is a cost savings. So, you know, we're not there yet. We're very immature. It's 5-year data. But I think in 5 years from now, if we had the same lecture, I think Urolift will fall off favor. It'll be in the same bucket as the great tuna and TUMT, where it creates a short-term benefit, but really you're not doing anything to the source, which is BPH adenoma. So I foresee that down the road, maybe costs will come down. Other companies will have other situations, and maybe in the steam, we can add in some other molecules that will also have long-term benefits. But it kind of makes sense. Everything's pushing toward office base. And this to me is the only office base. As a urologist, I'm in my clinic, I'm busy, I'm seeing patients, knock, knock. I come in the room, hi sir, endorectal probe, freeze 40 cc's. I tell my Alexa to start 15-minute counter. I come back, do my clinic, and then knock, knock, we're ready. The patient's lithotomy. I go in with like as if I was doing a cystoscope, but I pull back, inject, 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 pull other side, inject, inject, inject. I walk out, this nurse puts the catheter. So in a busy practice, personally, it's very easy to introduce this. I don't need a learning curve. I can show each one of you in 2 cases how to do this. It's really not hard. Outside of, you know, if you have 2 eyes and you have a finger, you can do this. So to me, down the road, I think outside the economics, which is the really inhibitory factor of this to me is the surgical pill.
True. Naeem, regarding the thermal leak, whatever the energy used for enucleation, what is in your experience the urethral stricture and the sexuality concerning the depth of the energy into the bundles? I know that you heard about the bipolar, the strictures, urethral strictures. What about the HOLEB, THOLEB? And the second question about the sexuality and the depth of the energy into near to the capsule.
Yeah, so it's a great question. Obviously, HOLEB and thulium, holmium and thulium both have depth of penetrations under 0.4 millimeters. You cannot affect erectile function with that. It's impossible. So there's no impact on erectile function. For the bipolar, obviously it's a cautery, so it is, the depth of penetration is deeper. There is a little bit more risk, but from everything that I've read in terms of data that's out there, the increased risk is not significant, and I wouldn't be concerned with that. If you're comfortable with bipolar enucleation, I think you'll do a great job. The truth is, a lot of the procedure is done manually, right? You push up the prostate into the bladder. The actual cautery is just for the bleeding. So I really don't think that's a concern. Stricture in bladder neck stenosis is very low. You know, with holmium, it's like less than 1%. Bipolar, from what we see, it's very low as well. So I don't think that's a concern. I think that if you feel comfortable with bipolar enucleation, button enucleation, I think you should go for it. I think it's a great technique, and your patients will be very happy.
Good, excellent. And we have a big data, Kevin, about the GreenLight, and we heard about the dysuria and the storage symptoms that bothers the people with the GreenLight. What in the other modality like Rezūm, because people that are talking about the steam, then the necrosis, do you find the storage symptom and the dysuria will be the same in Rezūm as in GreenLight?
So I don't think so, and from personal experience too, there is the initial post-catheter removal where there is some exposure of urine to the inflammatory state. The benefit of the Rezūm is that, guess what? It's one of the few procedures that we spare the skin, the urothelium, are puncturing through it and delivering energy into the adenoma. Whereas for GreenLight and HOLEB, and where it's the innocent bystander, that's the skin that protects it, and we rip it off, we morcellate it, we vaporize it, we got to get through that, and then we look at a 7-year-old man and say, now you got to heal. Like if you took on an 80-gram prostate, the surface area that you just denuded the urothelium, you need a skin graft. We don't do that as urologists, and it's bathed in urine. You drink lots of water. The treatment is time. Eventually, they're going to heal up. And as long as you didn't undertreat and create, a small area where all wounds contract, you'll get a stricture, or you'll get the syndychia. So if you go to capsule and you side fire along the capsule, don't create a lot of energy damage, and like an eschar, like in plastic surgery days, you leave a lot of this necrotic tissue. It's not gonna, the macrophages can't get rid of it. So get as smooth of a defect, get as much necrotic tissue out of the way, and then depending on the age. So I think the dysuria is just part of the, you know, the damage of the urothelium. I expect that usually within 2 to 3 weeks to resolve. So if someone's having a lot of dysuria at 1 month or 2 months, something's going on. Scope them. Is there a fragmented piece? Is there some calcification? So if I said, hey, look, you did an appendicitis and it hurts here, your first thing is I'm going to expose I want to see the wound. So I recommend, as a learning point, anything you guys do, if you go into a practice and a month or 2 months, the patient's not doing well, look at the wound. Go ahead and scope them.
Okay.
So, you know, I think dysuria is so interesting because these random patients will have dysuria, and I don't think we quite understand which patients get it. You know, Kevin, you mentioned how we don't burn the urethra, the urothelium when we do Rezūm, but the #1 side effect of Rezūm in the study is dysuria. You know, why are these guys having so much dysuria? And if you don't know which patients get it, or why they get it, Kevin's right. You scope them, you make sure there's nothing going on. But you know, I'll have a patient I did a hole-up on, and it's hurting. It's a year out, and you know, he pees, it says it's still burned. And I go look in, everything looks great. So I think there are some patients that we just don't understand why they're getting it.
True.
So if I may add one more thing, is that as BPH, we're all talking about BPH, we're forgetting about the next door neighbor, the bladder. And I think a lot of these patients outside, we don't do urodynamics on everyone. And even if we did urodynamics, it doesn't always capture what's really going on. There's an associated overactive bladder and bladder dysfunction in a lot of these patients. And although we remove the BPH, we don't always cure LUTs. There's remaining LUTs that tend to be irritative. And, you know, that's where, I don't know, you know, I'd say about 20% of my patients after doing some bladder outlet obstruction are requiring behavioral modifications or anticholinergic or beta-3, be it temporarily, until the relief of BOO improves their detrusor. Kind of like the reverse. If you went to the gym every day, you have a very big muscle, you're a muscular guy, and you stop going to the gym, you don't atrophy right away. It takes months for that and everything to come back into place. I look at that as the same function for bladder. And the dysuria is a mixed bag of, is it the fun, the frequency, urgency, nocturia, or is it genuinely burning when they urinate? And sometimes they get overlapped in the same bucket.
Abdulaziz?
Great. I think we have some questions in the chat, but most of them answered by our speakers. Let's have when we talk about the future for chronic prostatitis, do you think we'll have any role for these procedures in the future to treat prostatitis, especially Rezūm?
So I think the microphone sounded a bit like Darth Vader for a minute. So I'm not sure if I'm the only. It seemed very. But I think if I understand correctly, is that do any of these techniques potentially have benefit in prostatitis?
Yeah.
Yes, exactly.
If you're a pure CPPS patient, I do not think anyone on this phone call would say, hey, this is a great idea. I think probably in my history, a lot of these patients have voiding dysfunction, and on a Euroflow, I always look for DSD. Pelvic physiotherapy is probably underutilized. So I like to send a lot of those patients. I'd get that into play first. Unless it's truly a bacterial prostatitis where they're not fully emptying, and by relieving the obstruction, but I would not go with a steam-based like Rezūm. I think that may make things worse. I think getting them open would be the way to go.
Yeah, I have a few patients who HOLUP has done wonders for them, but I think, as Kevin mentioned, it has to be the right patient. Either there's a chronic infection that we can't get rid of, or they have some obvious obstruction, bladder stones or whatnot. So it can work, but it has to be in the right patient.
Ahmed, do you have questions?
Thank you, Said. First, I have a couple of questions for Naeem and as well as Dr. Zorn, who welcome him to join us, hopefully in the future in Riyadh. For Naeem, actually, you spoke about the aquablation in your sub-analysis. You mentioned the 80% they had preserved ejaculation. Just could you emphasize on the tricks that you're doing regarding the mapping of the area of verumontanum? What exactly you do to prevent retrograde ejaculation? So can you emphasize on this, please?
Yeah, so great question. So the truth is we don't know exactly what's going on or how we're able to do it, but the two main ways we're able to maintain the antegrade ejaculation is the butterfly cut, which I had showed in the video, and the second way is to not go too deep below the verumontanum. So what the robot does is once you've identified the verumontanum and the sphincter endoscopically, it will, when it comes closer to the vero, it will do a butterfly cut. So it will basically do both sides of the lobe, but it won't go over the verumontanum. So you preserve the verumontanum, you preserve the sphincter, and when you map, you try to not map below the verumontanum. So as long as you stay above the verumontanum, you will not cause retrograde ejaculation or an ejaculation. So the two main things is the butterfly cut that the robot does by itself, and in the mapping, you don't want to go too low on the vero.
I just could add to that. If I could just add to that, I think Aquablation has been great. Just like the robot has taught us after we've started doing them a little bit more of the microanatomy, to which back in the day of residency, it was all about the bladder neck, right? Bladder neck. And then you realize when you do a whole up or GreenLight, the bladder neck's wide open. But with GreenLight, people are starting to do this sort of apical hood. Is it the tissue or is it the fact that you're not damaging the ducts? So to me, kind of like the idea of how deep you go in the butterfly cut, is it really the apical tissue, or is it the fact that if I burn through your ureteric orifice, you'd agree that nothing's going to come out of that orifice. So if I obliterate not just the verumontanum, but the ducts, beyond the verumontanum hole, what do we know? Have we ever explored that? That's the issue. It's the ductal system and the main guts there. If you blast them and preserve the vero and you go deep behind the vero, well, it makes sense. There's nothing connected to it anymore. Nothing's going to come out. So it's a simple things. And to me, it's about that. It's the periverumontal anatomy that's preserved, be it the butterfly lateral cuts or is it the deeper stuff? And Naeem's paper showed it's the deeper stuff. So to me, that's what really what it's all about.
Naeem, let me ask you one question, please. You just showed the aquablation and the 0-5 learning curve, and this is very nice, but don't you think that this will shift most of the urologists to the easy job because it doesn't have a learning curve? So that's the problem with the HOLIP. So people will overtreat with the aquablation and Rezūm more than the HOLIP, which is the true enucleation. So how do you, I know you are an expert, you have everything, but most of the urologists, they just will be trained on one or two options. So how do you, the question is as well for Kevin as well.
So great question. I'm going to make 2 points before Kevin speaks. So first is, we've been trying for everybody to learn enucleation. We've been trying and trying and trying and trying. It's tough. I mean, there's more interest, but that learning curve to urologists is like kryptonite. They just cannot get over this learning curve. So that's number one. And number two is, I don't think, Saeed, everybody requires an enucleation. I get a lot of these 70, 75-year-old men, 80-year-old men in retention. They just want the catheter out. They don't need a full enucleation. It's going to take me 2 hours to get this 200-gram prostate out. And, do they really need that? We know there's not going to be the regrowth, but they won't live long enough for that prostate to regrow. So your point is well taken. I think it's an important point. I'm a true enucleist, but I'm also a realist.
Kevin, what about you?
Well, this is it. I mean, as I mentioned, I was born into this world of urology through the eyes of Al-Hilali. I learned prostate anatomy. I love the capsule. Then I went to Sherbrooke and I was like, what is this meat show? It's just like carving out, what is bleeding everywhere, but like patch it up and leave a catheter. So to me, it was traumatizing that. And I thought, wow, why this is the way to go. I love robotic surgery. I love anatomy. I love it. It is awesome. But for me to get paid the same amount of money to do any procedure, the code in Quebec is a 6247. I get paid the same if Naeem does a 2-hour hole up or I do a 60-minute. There's no benefit. And not to be mean, but again, I think to a very busy practice, if you're only going to do the same surgery over and over and over, it makes sense. But most people on this phone call are doing stones, you're doing ED, you're doing clinic, you're everything. And the amount of surgical volume BPH you do a month may be 4 or 5 cases a month. So it's hard to go to the gym 5 times a year and expect to get big muscles if you're a gym guy. So, you know, outside of a fellowship or a residency where this is like Dr. Lingaman, where Naeem was probably doing 5 a day, you know, from all over the country. So the volumes there that you can, after 50 cases in 5, that's 10 days. Naeem's curve is 10 days. He learned how to do a hole up. So outside of having that, you know, we all have the forgetting curve. So we have this call today. In a week or two, you guys will only remember about 30%. That's just the Ebbinghaus forgetting curve. It's a published thing. You can look it up. So there's the learning curve and the forgetting curve, and they're competing against each other. So to me, you know, the idea of, you know, Dr. Dasgupta, Prokar Dasgupta from the BGOI editorial, his idea is that aquablation will democratize BPH. So if someone comes to Riyadh or they come to Montreal and they get a aquablation, you know, and the patient knows that they're going to get a good outcome. So are we, and if anything, I think with the butterfly cuts, we can talk about ejaculatory sparing, but Naeem, you could speak a lot more of this, especially in the 80-year-old guys and plus. I think the incontinence rates will be a lot lower because with a hole up, outside of treating the apial tissue, if you actually watch the newtons of force that is exerted of cranking and getting into the plane and working the plane on those 80-year-old thinner sphincters, sometimes it's not recoverable. And so I think that's a big cost to be factored in. So I think you can undertreat, but I don't think it'll be overtreated. And to me, everyone on this phone call, I think one of the reasons we've all chose urology, we love technology. We're probably amongst all the surgical specialties, we have a marriage of ultrasound and robotics, and we're quick adopters. And to me, this is all in one. So if you have an iPhone and you're multitasking, this to me is no different. And it's an extension of our advancement in ultrasound and, you know, robotic execution. Being a Da Vinci guy, if I leave the robot alone and nothing's going to happen. With aquablation, once you planned it, that's the learning curve, the planning and the docking. That's what takes the most time in the procedure. You press a pedal. The procedure is done by the robot. So to me, I dream down the road, kind of like a Star Trek, where the machine will do the procedure. We set it up and we monitor it. So I don't think negatively. I think it's a good option on the road, given the fact that even Gilling, who learned hole up, he loves it. He's the actual fundamental leader of this movement for aquablation because he thinks we can do as good of a job in less time. And to be doing these procedures, like, you know, experienced aquablationists in Germany, they're doing these procedures in under 40 minutes. And given everyone's busy schedule, I think that's an attractive thing for us all.
Ahmed, you have any questions?
Yes, actually, for Dr. Zorn, regarding the dysuria post GreenLight, have you noticed any change regarding the technique? Because you used to do vaporization, then you do the like segmented enucleation, I would say. So any difference in the dysuria post-operatively regarding these different techniques?
Yes, so we actually published on that with Azizi et al. I kind of moved through the slides because I was trying to move on time, but one of them was our VIT versus PVP. And we reduced, aside from having better outcomes and better PSA reductions, there was less 90-day visits back to the clinic, specifically for dysuria. I think that's accounted because by doing those initial incision grooves, the energy then is being shot parallel to the capsule versus at the capsule. So instead of seeing the center of the circle and firing always toward PVP, we get down a capsule and the energy is always sent along. So the amount of coagulative necrosis is a lot less. And so with that, I think we're seeing faster epithelializations and less dysuria.
So my last question regarding the Rezūm, do you think I think you mentioned that, but any difference in the indication? Do you have softer indication for Rezūm as compared to other procedures? For example, if you put the patient on Flomax and he is complaining of ejaculation, I think maybe Rezūm is could be a first-line option for these kind of patients. So what do you comment on this?
So, I mean, if we could eliminate cost altogether and just purely offer these to patients based on, you know, the tool that we're, you know, coming out with, this patient decision aid, I think that would be the best option. You know, I think if you can nail in the butt earlier, because Flomax, as we all know, buys us time. We give Flomax, hey, you're peeing better, great, but you're not stopping the process. It's a slow time ticking bomb that's going to continue to grow. And later on the line, we'll bring in the 5-ARI. So FlowMax initiation to me is an opportunity to potentially get patients into the discussion that maybe if FlowMax isn't working to your liking, you can think about that. That's a nice way of introducing it. Maybe not the the next treatment if they're having ejaculatory. You can also try Cialis-5, which works really good and preserves ejaculation too.
Excellent.
Underutilized.
So my last question for Naeem. Naeem, regarding the bleeding post aquablation,
He's not.
do you still? He left or?
No, I think it got disconnected. But
Okay. So there's let's take a question from the audience. There's a question regarding the local anesthesia for the Rezūm. Is it effective? Is it enough? Is it or you just need to give something sedative for the patient?
It's a beautiful question. So that's something that Dr. Elterman in Ontario, Toronto is looking at his series, where he also does them in the office, but we'll use something called Penthrox. It's an inhaled halogen. It's kind of called the green whistle. So he learned about it in Australia. So if you break your leg and you're sitting with an open fracture and you're being wheeled off for an ambulance, the ambulatory ambulance guy can give you this green whistle, pour this liquid, and it looks like you're like smoking a crack pipe, and you just kind of inhale a few times and you get a buzz and you feel very little pain. So with his VAS, it's something that can be administered in less than 3 minutes. It's about $50. The patient will bring, it's done an observation by the doctor. So he's not doing a periprosthetic block. So he's seeing good results because as an Ontario guy, he's not allowed to do ultrasound or not confident with the skill set. So if you are someone who's doing a lot of biopsies, and maybe you can give me the background in your regions in Saudi Arabia, is transrectal ultrasound a urologist thing? Are most urologists skilled and trained with transrectal ultrasound?
They are actually.
So if that's the case, in my experience now, 70 patients that I've done, is to do this with a 40 cc block. I'll inject 10 at the standard seminal vesicle base and tip, inferior, and then superior. I go actually puncture through the seminal vesicles and treat anterior to the seminal vesicles, another 10 cc's, then 5 at the apex, and do that bilaterally. Let it sit for 15 minutes. Sometimes we forget that. We just inject it and we start doing biopsies, and I give you freezing. It didn't work. Well, we've all been to the dentist, and the dentists seem to do it. They freeze you and they walk away for 15 minutes and they come back, half your face is numb. There's a time dependency. So I'll do that and I'll see 2 or 3 patients, and then I'll come back and I'll do the procedure, which mimics a cystoscopy.
Great.
But before that is the lidocaine. So my VAS are between 3 and 5 as a modal number. And I've never had to stop a procedure to administer more anesthesia. So that's it.
Great. So my question to Naeem. Naeem, regarding the bleeding post aquablation, so do you still go and cauterize that bleeders routinely, or just you depend on the catheter? And if it's so, what's your technique for the catheter beside the machine that you use and you abandoned at the end? So do you still do cysto for and fulguration of bleeders post aquablation? So what's your tricks for bleeding post aquablation?
Yeah, so great question. So we abandoned the catheter tensioning device. So forget about that. What we do is at the end of the procedure, we'll evacuate all the clots, all the tissue. We'll go look in. If there's bleeding from the bladder neck, we will cauterize. This occurs in about 1/4 of cases. If there's no bleeding, we put a catheter in, put a bit of traction, fill the bladder up, plug the outflow, take them to recovery room. About half hour, 45 minutes later, we unplug. Urine is clear, we're good. Urine is a little bit bloody, we'll manually irrigate and then put it on traction. I think that there's a balance between cautery. We want to keep this as heat-free as possible, obviously, but if we need to, we will use it. Just being, very come to the recovery room, make sure that the urine remains clear. With that, we're able to get 0 transfusions in the cases that we've done. So there is some bleeding. I think transfusion rate is settled around 2 to 4%, depending on the size of the prostate.
Thank you.
In fact, I think the key element here is the bladder neck. And so once you do the aquablation, you're looking at sort of an open pit with some coagulated. By then, the bladder neck, once you start moving from bladder neck to the apex, you'll get clots that form. So first thing that you want to do is get rid of those clots with brush them away, and then you'll resect specifically at the bladder neck. So I don't think it's a ubiquitous treatment throughout the whole prostate. You're really looking at the bladder neck at 5 and 7. As we know, that's the entry points of most of those bleeders. And even with the balloon, they'll bleed underneath of it. And that's what we found as being the key elements for good hemostasis.
Great, great. I think maybe it's the time to conclude. We are over 90 minutes now, and as we planned, at the end, it was a great pleasure to have you, Dr. Boujani, Dr. Zorn from Montreal. We thank you very much for the great talks and discussion tonight. And we would love to have you in person in Saudi Arabia, inshallah, soon,
Inshallah.
so, after this pandemic. So at the end also, I would like to thank my colleagues here, Dr. Saeed bin Hamri, Dr. Adil and Dr. Ahmed for the great organization, and hope we'll see you soon all. And I'll leave the final word for my colleague, Dr. Saeed bin Hamri.
Thank you, Abdulaziz. Especially thanks to Dr. Ahmed for gathering us, because Dr. Ahmed Al-Askar is a colleague and a friend. And 30 years ago, we were thinking about monopolar, bipolar. I'm so excited to see all these technology in your hospital, guys. You are lucky, you are references, and we will meet soon. And thank you very much. Thank you very much. Thanks.
Thank you. Thanks, everybody. Thanks, guys. Good job.
Thank you.
Bye-bye.
Great work, guys. Bye-bye.
Bye.
Good night.
Good
Good
night.
night.
Kevin, you don't know where to. He left.
طولنا.
It's okay.
I'll-
It's very enjoyable talk, I have to say.
صحيح. صحيح.
Thanks, guys. That was great.
Thanks.
Have a good night.
Have a good night.
Good night.
Stream.
نراك على خير أبو يوسف. مع السلامة.
All right, نراكم على خير, and this is the end. See you. Bye-bye.